Hello, everyone, and thank you for joining us for Chapter 2 in our 4-part series on transforming healthcare into health creation. Today's presentation is titled Chapter 2, Redefining Lab Operational and Clinical Excellence, and it's presented by Jeremy Schubert, Divisional VP, USO Commercial Operations at Abbott Diagnostics, and also joining us is Dr. Joshua Hayden, Chief of Chemistry at Norton Healthcare. I am Christy Jewell of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is brought to you by LabRoots and sponsored by Abbott Diagnostics. For more information on our sponsor, please click on the Abbott logo on the left side of your screen. Now let's get started. I would like to remind everyone that today's event is interactive, and we encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. We will answer as many of your questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, click on the Support tab found at the top right of the presentation window, or you can use that Ask a Question box to let us know you're experiencing a problem. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process to obtain your credits. I would now like to introduce to you today's speaker, Jeremy Schubert, Divisional VP, USO Commercial Operations at Abbott Diagnostics, and Dr. Joshua Hayden, Chief of Chemistry at Norton Healthcare. For complete biographies on our speakers, please visit the Biography tab at the top of your screen. Gentlemen, you may now begin your presentations.
Thanks, Christy, and good morning and good afternoon to all of my laboratory amigos that are out there. I hope everybody's staying safe, throughout this process. We want to start today by just saying thank you to everybody on this call and all those that will be listening later from a laboratory perspective. We all know, being in the lab business, that the laboratory is the unsung hero in healthcare. We are the decision engine that really makes it go. And unfortunately, there's not a lot of recognition for that. However, nothing has like this crisis has heightened the attention to just how important diagnostics is. And the work you guys are doing out there every day to flatten the curve, to keep our community safe is extremely valuable, and we can't thank everybody enough and appreciate everybody enough for the great work that you're doing each day to facilitate getting through this crisis and actually creating healthier communities on the other side of it. As I've shared with my team, all of these crises as they happen, they do one of two things. They either strengthen or they weaken. And this is an opportunity for the lab industry, for all laboratories to strengthen to this process and to demonstrate their real contribution to the health and well-being of their community. So thank you. What I'm going to do, guys, I'm going to give you today is a kind of a quick recap of what we talked about in Chapter 1 around the kind of the future of healthcare and what's driving it. And then Dr. Hayden is going to talk a little bit about how we use the data that we have and take a really new turn on this concept of more with less and what the laboratory's role can be in that. And then I'll take a quick summary at the end. So let's begin with what we talked about last time. And I'm going to break this up into 3 components. One is just how quality has been redefined. 2, what is health creation and what does that mean? And 3, what is the environment? What are the environmental factors that we have to consider from a lab leadership perspective to be able to make massive impact? And I'm going to start with a slide about my good friend, Michael Elop. For those of you on the last call, this is the CEO of Nokia and his famous statement about we didn't do anything wrong, but somehow we lost. Again, the central theme here that we have to carry through is this is not about doing something wrong. It's about ensuring that we're doing the next right thing, that we're preparing for what's next, that we're developing new skills, new competencies, new processes that facilitate forward movement in healthcare. It's not enough just to do a good job. We always have to be considering how we're getting better, how we're developing, and how we're preparing for what's next. And that the last time we talked a little bit about how healthcare was changing and why. And we rewound time back to the year 2013, where, in fact, actually in the U.S., medical error was the third leading cause of death. And our central theme here was not that our U.S. healthcare system's bad, because it's not. But what it was, the central theme is that we can do better. There are things that happen that are diagnostic errors, that are just general error in general, that are impacting patients in a negative way. And so what this was is a call to action for us to rethink what we were doing as a health system, redefine what quality is, and for everyone, with all the constituents within the health system, to take a step forward, to change, to develop, and to grow. And so that actually spurred my first point that we have to carry forward from last time, which is the metrics that we should be looking at, the things that we should use to assess how good we're doing, are not turnaround time, and they're not cost per test. They're centered around the CMS metrics that were developed after 2013 because of this medical error impact to the leading cause of death. And it centers on things that are important to the patient. And the call to action from a laboratory perspective is that we need to align our thinking and our contribution to how we affect metrics like length of stay, like readmission rates, like hospital-acquired conditions. Those are the things that we have to think about the role we play. Because if we do not play a significant role in moving those metrics in a positive direction, then we are not relevant. It doesn't matter that we create most of the data that's used from a medical decision-making perspective. If we're not facilitating good decisions on the other side, we're not going to be relevant. The second topic that we started to approach was how health is changing. And the central hypothesis here is this is going to move from healthcare to health creation. No one is going to expect to be treated from an acute, a chronic, or even a preventative perspective. People want to be treated as a whole person. So health systems are going to have to redefine their approach to be more holistic and cover the entire life course of a person. By the same token, we talked about how you can learn more about a person's health and their prognostics from their zip code than their genetic code. And so social determinants are going to become an ever-growing and increasing element to what we have to consider in how we treat patients. We also talked last time about the fact that it wasn't about personalization, it was about engagement. For sure, personalization enables engagement, but personalization in and of itself is not sufficient for a healthcare system to advance. So part of what we have to think about is how do we participate in a world where the laboratory can bring strength to patient engagement. And finally, the thing we have to prepare for is the fact that people are not going to want to experience healthcare in the traditional sense. They're going to want to see it integrated into their daily lives. Now, this is going to be actually accelerated since the last time we talked, because you can imagine with this COVID crisis, this is going to facilitate a new need for people to want to experience care without having to go to a facility to experience it. This crisis is actually going to accelerate a change in telemedicine. This crisis is going to accelerate a change in alternative care models, a change in triaging of patients before they get to the hospital, a host of other things that are going to happen, simply accelerated by this crisis. But it's going to fit into this domain of the fact that people want it integrated into their daily lives. The final topic that we hit on was kind of this construct of, okay, well, how does that work? And trying to think differently than just, hey, we have our health system, because we actually have two other components that we have to figure out how do we integrate and align with. When you think about the social determinants, we have all these community resources that are there to support the well-being of the population, of the community. And then you have this concept of the home and what really is the daily life of people. And the question really is how do we connect all of these things? How do we make them work in concert? And effectively, how do you create healthcare without walls? Again, not having the foresight of the COVID crisis, but this is exactly what is stressing our system right now, is how could we manage patients who are self-quarantined in a way where kind of healthcare becomes Wi-Fi around them. And if you think about if we already were at this point where we could coordinate all these resources, we would be much more effective at dealing with this crisis. Because again, what we'd be able to do is deal with patients as they self-quarantine at home and mobilize all the community resources to support them. So the sense of isolation, the sense of fear could go away because the sense of support would be there. Unfortunately, this doesn't exist today. And why that doesn't exist is simply because, as you see on the slide here, there needs to be connective points, bridges, that connect this external data into the health system and then bridging from the health system to the home and to the daily life of individuals. If these bridges existed, we would be in a much better position to react. And so the whole central theme of that was just this, that from a lab perspective, it's not sufficient for us to measure the future around automation. Automation is going to be important. It's going to be necessary, but it is not who we are. The future of lab medicine is going to be measured by our ability, each of us, to step in and take a leadership role in the decision-making that happens in the clinical pathway, strategically, operationally, not just within the four walls of the system, but in a system without walls. And so what we postulated in the last round was, there are 5 things that, that steps that laboratories should be taking to facilitate developing competency and capability in this, which we're not going to review today. But as we go back into the COVID crisis, I want to bring back my good friend, Mr. Elop, okay? Now, again, as we kind of approach this, we have to be thinking about, is we're going to look back at some point at this crisis, and it's going to teach us some very valuable lessons about what we could have done differently to be ready, what we could have done differently to be empowered. And this is also an excellent opportunity for us to educate the broader health community about the value of the lab. Because as we all know, lab medicine should be the leader in this crisis. And there's a number of scientific publications that walk through pandemic and epidemic after pandemic after epidemic and walk through the role the laboratory should play, the role diagnostics should play. And as this highlights in this article, that clearly that diagnostics is fundamental to the approach, and it actually highlights the fact that there are developmental needs that need to take place from a diagnostic network perspective for us to be effective at dealing with pandemics and epidemics. And that's not development of new technology. That's not just the development of informatics. It includes people and process in addition to technology that's important. And as the organization FIND kind of laid out, it's not just that when we're at the heat of the crisis that diagnostic plays a role. There's a surveillance front end and back end that's really, really important. So at some point, this could very easily die away as we get new tests out for COVID, that people go, okay, well, now we can do testing, diagnostics fades to the back. That can't be the case. In fact, on the post-surveillance side, we have a big role to play, and we need to be prepared to play it. And being prepared for a future element or a future emergence of a new infectious disease, of how we would manage that. And so staying on top of changes that we need to make in our operating model are going to be really essential. In the end, it all boils down to the fact that an accurate diagnosis is the first step to getting effective treatment. The World Health Organization knows that. Healthcare knows that, and we're at the center point of it. And so part of our job has to be, how do we use the available resources and tools and data, that's what Dr. Hayden's going to talk about, to help us get to that accurate diagnosis faster and more efficiently. At the end of the day, the things that I would encourage you to think about as we go through the rest of this presentation is the following. There is a scale of value, of impact that you make as a laboratory, right? And from the basic level of business continuity, of operations, of turnaround time and cost per test, that's important and essential, but it's low impact to the overall health system. But as we move up to the hospital and the system level, really focusing on their KPIs and putting ourselves in a position of affecting readmission rates and length of stay, that's where we start to create value. And if we build a system and a model that helps us, and no matter what disease burden it is, because it doesn't have to be infectious disease, where we're really understanding and being able to anticipate shifts in the population, deal with crises as they come, and handle the post-surveillance so we can learn and grow and develop and get stronger as health systems. That's where labs create maximum impact. And to do that, if you have no tools, right, that's a challenge. If you have tools that sit in the EMR, that gets you somewhere, but that doesn't really enable you to be the best of who you are and make your maximum contribution. And so this is about making sure from a lab perspective, there's a dedicated strategy and control of the tools and the processes that enable this type of analysis, insight, development, and deployment to occur. And so that's why I'm excited to turn it over to Dr. Hayden, who's going to talk a little more about this concept of more with less from a different angle and show us his thoughts and how to apply this type of thinking in vivo. Dr. Hayden?
Thank you very much, Jeremy. And yeah, I'm happy that everyone was able to take the time to join us today. I think it shows maybe one of two things. Either one, you're a chemist like me, which means it's your microbiology colleagues who are running around crazy trying to figure this out, or hopefully it means two, you recognize that we're going to get through this challenging time and we can't lose sight of doing those important long-term things which are going to make us so much better 6, 12, 18, 30 months from now. And I think keeping that eye on the long-term goals and strategically moving forward is really, really important. So thank you all for coming. And as Jeremy said, we're going to be talking a little bit more about doing more impactful testing with less waste. Just for disclosure, support for this program is provided by Abbott, and I am presenting at the request of Abbott. So some of you might not be familiar with Norton Healthcare. So Norton Healthcare is situated in the Louisville, Kentucky area, although our primary service area is about 16 counties with about 1.5 million people, with almost 3/4 of our patients coming from the Jefferson County area. And we have a range of health conditions which are impacting the health of our communities. And these health conditions then become our areas of priority. These are areas where we want to focus additional efforts. Not surprisingly, heart disease, cancer, diabetes are at the top. We also have Norton Children's Hospital, and so children's health is always an essential area of priority for our health system. And in case you aren't too familiar or you're still not terribly interested in what Norton Healthcare does, I will mention that our system of 5 hospitals, 7 cancer center infusion labs, and dozens of Norton Medical Group and ICC areas also cover the Louisville area, which accounts for the vast majority of the world's bourbon. So in case you're like me and you often find yourself needing to go home and get a drink at the end of the days recently, remember we're helping to keep that bourbon distilling. One of the things that I've really liked about Norton is that as a system, we've tried to focus on doing more for the health of our communities. And I think one good example of this would be our flu tracker. So Norton started this some time back. We put it up on the website to allow people to go in and see the cases of diagnosed influenza A or B per certain number of residents in their geographic area. All right? So why do we do this? Well, because as we're all learning, understanding where communicable diseases are highly prevalent is an essential step to reducing the spread of those diseases. I certainly appreciate it because it helps me see where I might maybe not want to go to a child's birthday party, for instance. But I want to mention that when we're looking at this data, the only reason we're able to display this in an effort to help our community health is because it's built around essential, accurate diagnostics. Right? This is the sort of communicable disease tracker that would be fantastic to have when we have these new outbreaks, such as COVID. Unfortunately, we don't have those essential diagnostics. And without that key first step, as Jeremy mentioned, you can't take any of the subsequent steps. Okay? It's also why I think that doing molecular flu, like we do at all of our hospitals and all of our medical group offices, is an important and worthwhile activity. Yes, it is substantially more expensive, but I believe that that expense is worth it given the value and accuracy of that result. Because I think that molecular flu is a great example of us doing impactful testing, which is really what we want to be doing more of. So what is impactful testing? So I took a stab at a definition of that. I would consider impactful testing a laboratory test that is required for and leads to improved patient care. And it's really those two elements, required for and leads to, right? So required for, we do a lot of testing where the patient's care path is going to go regardless of what that result came back as. And that's not impactful testing. Furthermore, the laboratory test has to actually lead to improved patient care. Right? So Jeremy was talking about medical errors being a third leading cause of death. You know, one thing that we've learned, one of the most common laboratory medical errors is a failure to retrieve error. That means that there is some essential laboratory test out there in the patient's record, very often the electronic medical record, which is never retrieved, never acted on, and because of the failure to retrieve and act on that result, patient suffers harm. Right? So impactful testing needs to think about how can you ensure that appropriate patient care and next steps are actually taken. So what is an example of impactful testing, which I think we've been able to do here at Norton? So one example would be HIV testing. So for those who might not be as familiar, there's 1.1 million people in the United States who have been diagnosed with HIV. Now, out of that, just over a million individuals, it's estimated that 1 in 7 are undiagnosed. They're unaware of their HIV positive status. Studies have shown that those undiagnosed individuals account for 80% or more of the new infections. Right? So think about that. 1 in 7 individuals, a minority of those living with HIV, are undiagnosed, and yet that small percentage of individuals accounts for the vast majority of new infections, with estimates showing that every 100 undiagnosed cases of HIV leads to 8 new infections. So if we can actually test for and diagnose people with HIV, that is a very impactful testing, because not only can we alter the care pathway of that individual who was previously undiagnosed, but we can also reduce the risk of them spreading it to others and creating new cases. This is why the U.S. Preventative Services Task Force actually put out a recommendation that individuals between the ages of 15 to 65 years of age be screened for HIV regardless of risk factors. Right? So one of the things we wanted to do at Norton was to say, how good a job are we actually doing screening individuals for HIV? And I want to recognize here the tremendous work by the STI Task Force, led by Michelle Rose, who put together this data and have been influential in the efforts I'm about to talk about. So when Michelle and her team looked at the patients that we were actually testing, what they found was that about 3/4 of the individuals tested were women, even though men accounted for 3/4 of our positive results. Right? So once again, 1/4 of the patients we're actually testing are men, but out of that small percentage who are tested, they account for the majority of new positive cases. And this was a strong indication to us that while we were doing a better job screening women, especially in collaboration with our OBGYN colleagues, we were missing a lot of individuals who should be tested. And so we set about to implement universal screening. So how do we set up our HIV universal screening? Well, the first thing that we did is we called it an opt-out program, right? This is not that individuals choose to be screened, it's that individuals have a choice to not be screened. And that language is really important when your frontline providers are discussing with patients whether or not they want to be screened, right? Telling them that everyone is being screened unless they object, people are far less likely to object. So to implement this, we actually built a best practice advisory recommendation in the Epic EMR, and you can see that HIV screening comes up as part of your general assessment and triage of an individual. And if the patient does not opt out, then the lab tests will be done automatically. So what impact did this have in the Norton system? Well, we implemented the universal screening round about September, and you can see right away that our volume of testing increased substantially. Right? We started to use a lot more HIV test reagents, and the lab budgets were certainly impacted. And I think this is an important thing to remember, that there is certainly a cost associated sometimes with doing more testing. But I think we need to ask ourselves, first of all, are we doing more impactful testing? The cost of the test itself is trivial compared to the cost of undiagnosed, untreated HIV. I'm not, however, so naive to think that cost isn't a consideration, right? But we need to remember that in addition to costs, there are charges and revenue. And so with HIV, for instance, Medicare Part B reimburses for HIV screening. I listed the dollar amount from the recent fee schedule, though obviously that can vary by area. And Medicare Part B will cover this once per year if you're 15 to 65 or younger than 15, older than 65, and at increased risk for HIV. Right? So we build up our recommendations for universal screening to be consistent with these reimbursement guidelines. Now, certainly, uninsured individuals are a different matter, but studies have shown that Medicare and Medicaid individuals account for 60% of our ER visits, with private insurance, who almost always follows Medicare recommendations, accounting for 30%. So 90% of our patients are actually going to have coverage for this testing. But again, that's just the financial aspect. What about the clinical aspects? When we implemented the universal screening, we ended up in the following months diagnosing 7 new cases of HIV through universal screening in our emergency department. These were 7 individuals who were unaware of their HIV status, who were only discovered and diagnosed thanks to universal screening in the emergency department. So going through some of these cases, one thing I want to mention is HIV is a communicable disease, and while it is associated with certain risk factors, it doesn't discriminate in any way. Right? So certainly what we are seeing is that the rise of IV drug use as a consequence of the opioid epidemic is fueling an increase in some of these blood-borne pathogens, HIV, HCV, and we see that here with a high prevalence of IV drug use. However, even non-drug using heterosexual individuals are susceptible to contracting HIV. I also wanted to point out that we had 2 cases of acute HIV diagnosed. Right? And I want to point this out because, one, it's an opportunity to talk a little more about how we do our HIV testing and the time course of the disease, but also because it's important to remember it's not just about doing testing, it's about doing the right testing. So the CDC recommends doing a laboratory-based 4th-gen antibody-antigen combo assay, which is what we use at Norton. But that doesn't mean that everyone is using that. Individuals are still using 3rd-gen HIV assays, which would only detect the antibodies and would have actually missed these cases. So why is that? Well, if we look at the time course of HIV in relation to HIV testing, we have infection, which we can define as T0, and then there is a window period during which you're unable to detect the disease, and that window period varies based on the nature of the testing that you're doing. So early on after infection, you can see you have the rapid rise in HIV RNA as HIV is proliferating unchecked. The human body hasn't mounted any immune response. We actually see large decreases in the CD4 count, and patients at this point can reach levels of HIV viral load and low CD4 counts that they will not see again until the terminal phases of the disease. You then have a rise in the HIV P24 antigen, and in this area where we have the low CD4, high viral load, and P24 present, this is what we call the acute HIV phase. Then we do start to mount a serologic response with IgM followed by IgG with seroconversion in 1 to 3 months, and the viral load starts to go down. CD4 counts actually bounce back up. Right. So being able to detect patients in this acute HIV window is very important because that's when they're actually symptomatic and are more likely to present to a health system for treatment. And so you have an increased likelihood of detecting these individuals. In addition, because of the high viral load, they tend to be more infectious during this acute HIV period. And so it's essential, if you're going to be offering HIV testing, that you're following CDC recommendations and offering a 4th-gen HIV antibody-antigen combo. Beyond the 7 cases of new HIV that we detected, we also had an individual with known diagnosis of HIV who wasn't linked to care. And I want to talk about this because if you remember, I defined impactful testing in part by testing that leads to improved patient care. I know of medical centers who have implemented universal screening and have not seen that essential linkage to care. And if all you're going to do is do a lot of HIV testing and not have someone follow up on those results, connect the patients to care, help them address whatever barriers to care might exist, then you're not necessarily doing impactful testing, right? But of course, you can't link patients to care if you don't know that they need linked, right? And that's really what we're talking about doing with impactful testing. It's making the clinical laboratory an important link in the chain from patients to the care they need. So in the case of our HIV universal screening, we're talking about patients being tested in the emergency department, the laboratory producing accurate results, and then nurse navigators being around to do a tremendous job reaching out to those patients, connecting them to care, helping them through the psychological, emotional, socioeconomic, and health challenges that they're about to face to ensure that those patients get the care that they need. And I really think that that's what impactful testing does. It makes us a link in the chain. In order to do that, we do have to ensure that our test results are accurate, and we have to help spur necessary clinical action. And a lot of times that requires us getting out of our little laboratory silos and actually going and speaking with people. Too often I see situations where some of the things we do in the laboratory, we think we're properly informing or educating, and maybe we're not doing nearly as good a job of it as we think we are, right? And so to change gears a bit here, I think a good example of that is when we think about some of the interferences and limitations of our assays, right? So with your HIV, you should be doing a 4th-gen. If you're not doing a 4th-gen, what are you doing to ensure your providers know the limitations of the 3rd-gen? Or let's take drug interferences as an example. So here I will use Fulvestrant Faslodex as an example. So Fulvestrant has come out as a treatment for estrogen receptor positive metastatic breast cancer. It works by competing with estradiol for hormone receptor binding, and that prevents the driver of cancer cell growth and division. The problem, of course, is that one essential laboratory test in patients with estrogen receptor positive metastatic breast cancer is actually checking levels of estradiol. And that can get problematic because, as you might be able to see from the chemical structures shown here, fulvestrant works by being an estradiol analog. It structurally is very similar to estradiol. And that structural similarity is what allows it to work and interfere with hormone receptor binding, but it also allows it to interfere with the antibody-based immunoassays many of us use for estradiol. And so for this reason, there have actually been disclaimers out there about the fulvestrant interference in estradiol measurements and the impact that they can have to patient care. Right? And so this impact can vary from risk of unnecessary therapy modification to surgical intervention, which is unnecessary. So what do we as labs do about this potential interference? Or let's go a step further, right? What do our vendors do about these potential interferences? So what most vendors do, and I'm not picking on Abbott or the Alinity platform here, right? But this is an excerpt from their instruction for use, and they put a disclaimer that the assay should not be used to assess estradiol levels for patients undergoing fulvestrant treatment. An alternative method should be used, right? And I can tell you this is how every manufacturer in the U.S. currently handles these sorts of interferences. So does anybody here think your clinicians spend a lot of time reading the package inserts from your manufacturer? I mean, maybe a better question is, how many of us spend as much time as we should spend reading package inserts from manufacturers, right? And even when we do read it, our response is rarely much better than putting something in an IFU, right? What we do is we put some sort of information on a comment which is appended to every result, right? And how many folks here have seen what the comments look like? So what I'm showing here is an example of the visibility of our comments with one of the commonly used Epic views. And so what you're looking at is a snapshot with some laboratory results, and anything which is in italic with a little asterisk actually has a comment. And so triglycerides, for instance, has a little comment telling people what desirable, what borderline high, high, and very high triglyceride levels actually are. Fascinating reading, I'm sure. You know, the TSH, for instance, in this particular example, this was taken some time back. Our lab is using a method that has a biotin interference, and so we're putting an interference that this result may be inaccurate if the patient's taking biotin. Now, those two comments from a patient care standpoint are very, very different, right? The physician probably already knows what a desirable or undesirable triglyceride level is. They may or may not know about inaccurate results due to biotin, but in our current EMR, these are displayed exactly the same. And as a complete aside note, I'm also going to say these triglyceride comments and the cholesterol comments, it's always irksome to me, right, when we post something like a triglyceride level of 120 and then we append this long comment that tells them what it would mean if the triglyceride was under 150 or what it would mean if it was greater than 500, right? If we know what the value is, why shouldn't our comments be a little more tailored to what that specific result we're reporting means, not what the realm of possible results could possibly mean, right? Regardless, I'm not sure how much it matters, right? Because you can see these comments aren't terribly visible, right? Our clinicians do an amazing job looking through them because our clinicians try very hard to do what they can for best patient care, but eventually you get tired, right? And I think labs need to start to think, is there a better way for us to handle this? Whenever someone tells me that their lab handled something by putting a comment, my mind always goes to the Simpsons. There's a great episode where Bart has fallen down a well, and town of Springfield decides they can't ever risk that happening again, right? This is like when you find out about a patient safety event because somebody misinterpreted a lab, and so you put a comment, and then we think, oh, that'll fix it. And so what Springfield did was have groundskeeper Willie go and pound the sign that says caution well up, and you can see it's in front of the well, which has 360-degree access, and groundskeeper Willie thinks that should do it. And that's what I always think. Yes, this is maybe making us feel good, but are we really actually helping patients, right? Because what we need to do is selectively and in a targeted manner intervene to share the information which is needed for clinicians to get their patients on the best possible care pathway. And what I'm talking about, of course, really is clinical decision support, right? CDS. So how would that look for something like Fulvestrant, right? Well, the idea is that CDS could allow labs to prevent the release of results for patients with known interference, right? So when we have our provider taking a look at her patient wanting to measure a lab, right? All of that is data, the medications the patient's on, the lab order, and that can all flow in through a clinical decision support tool, which could notify the lab or even notify the clinician directly. I think in my mind, ideally, it's the lab, so we can have a conversation, right? And we can let them know, this test you ordered on this patient who's receiving this medication shouldn't be done, and we're going to help you. We're going to send this out to a reference laboratory doing a different methodology, such as tandem mass spectrometry. Okay. And I think this is where we really need to start going to ensure more impactful care. You know, Jeremy had that great slide where he talked about sort of the bridges, and I think for too long we've required the doctor to be the only bridge connecting this. And the reality is that's just not feasible anymore. They can't know all of the interferences that we have, and I don't believe that the current methods we have for highlighting those interferences in the EMRs are actually working. And implementing something like CDS can help ensure that we offer more impactful testing, right? And this is, once again, it's making the laboratory an important link in the chain and keeping our patients safe. Because really, when we think about the doctor having to act as that bridge, right, it's simply too much. And that's why folks have talked about healthcare moving from ignorance to ineptitude. And I don't mean ignorance or ineptitude in a negative manner. As I said, we have a lot of well-meaning individuals doing the best they can, but the scope of human knowledge has simply expanded to the point where we have far too many patients being hurt because of a failure to apply known knowledge. So actually this picture here is talking about mercury and how it was earlier thought to possibly be a therapeutic for syphilis, right? And it's easy to think about these crazy things that medicine used to do and wonder how they ever got that idea. But the reality is that was a time when ignorance prevailed. We simply didn't know how to treat syphilis, right? But they were doing the best they could, seeking out whatever knowledge was there. Now we're in a situation where the amount of knowledge which is out there far exceeds the capacity of the human brain to retain it all. Right? And so I think that we need to start to provide a little more help and guidance. And of course, providing help and guidance starts in the pre-analytic mode, right? It's ordering the right tests, right? And we can do that through a range of options. So some of the best practice advisories, right? We talked about what we did with the HIV opt-out screening, the universal screening. This is an example looking at hepatitis C screening from a published paper. But I'm going to mention that each one of these sort of, pop-ups and best practices, these all take a tremendous amount of time, and you're doing it on a case-by-case basis, and you quickly overload your practitioners, right? And I don't believe that we only have these single isolated incidents where this is necessary. I actually think that there's a lot of missed opportunities for testing. So if we just go back to sexually transmitted infections, STI testing, one thing I looked at was the nature of the testing coming out of our lab, looking at HIV, HCV, and syphilis testing. And these Venn diagrams are showing the numbers for how many times did we only have an HIV test, 956. How many times did we have an HIV, a syphilis, and an HCV, 1,531. We had 224 isolated syphilis tests, right? Now, I'm not saying that there aren't reasons why you might only want one or two of these, right? But it does mean that we need to think about, in general, what sort of STI testing should every patient be getting? And are we making that easier for our clinicians to order? Because when we have 298 patients only get an HIV and HCV, are we possibly missing syphilis in those 298 patients? Right? And when we get the right tests ordered, right, then we have to think about how that impacts the patient. So going back to the paper which had looked at increasing orders for HCV, what they found was that they were able to detect 53 new cases of HCV, but out of that 53, only 18 actually reached therapeutic goals, right? And so on one hand, that's great, because you have 18 patients who wouldn't have reached therapeutic goals without the testing. On the other hand, that means that you have 35 patients who were diagnosed as positive where no clinical action was taken, right? That's not impactful testing because the patient care pathway was not improved. And I think I've been thinking a lot about STI testing because really this is an area where the community as a whole has to think about where we're going to do this testing, how we make sure that all of these patients testing positive, or at least a greater percentage of them, are referred on to the proper care pathways. Right? And so Norton, for instance, operates on a hub and spoke model, and so we're thinking about where does ID serology fit into the hub and spoke model for clinical laboratories. Financially, it's best for us to centralize all of this, but is that best for ensuring that patients get on the right care pathway? Do we need to have this STI testing available at every one of the spokes in our health system? And no, that doesn't make the best financial sense, right? But I also think that we need to not fall into the trap of commoditizing ourselves, right? Because when you start to make the lab a commodity, then you get traded away, right? And we all know the challenges we face with PAMA coming. But we also know that when all you're doing is generating lab results for the lowest amount of money possible, then you are going to face pressures and you're going to be bought out. And it's happening all around our area and all around the country as larger labs exercise economy of scale. Larger labs who can think about what makes the most sense financially, not necessarily thinking what makes the most sense for the patients at this health system. And that's where I think we need to resist this. Yes, we need to be good stewards of our resources, but we also need to think about using our resources to provide value to our health system and our patients. And we do that through more impactful testing. And so with that, I'll turn it back over to Jeremy before we take some more questions.
Awesome. Thank you so much, Dr. Hayden. So just kind of as a quick recap, a lot of great content and kind of perspective and application that Dr. Hayden has shared. And it centers along the lines of how do we think about the role of the lab and how the lab can create value. And I encourage all of us as we're kind of going through this, to challenge ourselves to move beyond the concept of just automation, turnaround time, cost per test, and move into, as Dr. Hayden's outlined in his examples, ways that we could impact the bigger picture, whether that's readmission rates and length of stay, all the way to, as he rightfully highlighted, just taking some actions that can impact the population health with HIV. All great applications of leveraging the lab to create bigger value, both clinically and financially, for the health system at large and for the community. And as he kind of outlined, there's a way of thinking about this of kind of what control you have. And he artfully shared kind of even in worlds where we think the EMR is meant to play this role, is going to do this for us, at best it's an average impact because of how it's structured, because how comments reflect. And I'm not sure how many of us have actually been able to see the clinical lens of the EMR, but there's a reason why so many physicians have pop-up fatigue and burnout because of what's coming at them. And instead of trying to put more through the EMR, the really challenge for us is how do we have more control and take more of a personalized approach, an active approach in working side by side with clinicians and stepping in to that patient situation and facilitating better decision-making, better outcomes, and the like. And I think Dr. Hayden expressed that really well. And it kind of stays in line with this multiple domains of things that labs can consider. And as we shared last time, there's a number of ways to kind of approach at this. But, one of the best steps is to actually start just by taking an assessment, whether you do it yourselves or you get some outside help. There's a number of tools that are available for assessing kind of the situation and figuring out and determining what's the best way to align what you want to do as a laboratory, what you can do as a laboratory, to what your community and your health system at large needs. And that really is a different set of activities and thinking than maybe we get the opportunity to go through on a day in, day out basis. So it all kind of starts with assessing and building a strategy for it. One thing I did want to highlight for our customers that are out there from a COVID perspective, just as an aside, and for anyone who's actually interested, we're working through a number of things to try to help our customers through this crisis. And this more centers on business continuity, but just as more of a public service announcement, if you're an Abbott customer, there's a number of things we have going on to try to facilitate helping business continuity, both from a supply and service perspective. And I would encourage you to reach out to your Abbott representative to be able to participate in either virtual huddle with your team, and then we're doing a number of regional and national calls to facilitate best practice sharing, understanding kind of local incidence and prevalence, and being able to manage through and helping everybody support each other through this process. We were talking before the call began of just how important it is that we all help each other out. And we're setting up some mechanisms to enable that to happen from a lab community perspective. And anyone who wants to participate or wants more information for that, feel free to reach out to your representative or to us directly. So that being said, guys, we'll take some questions from the audience. Christy?
Thank you, Jeremy. And thank you, Dr. Hayden, for joining us and for your informative presentations. We will now start the live Q&A portion of the webinar. And to our audience, if you have any questions you'd like to ask and have not done so yet, please do so now. Just click on that Ask a Question box located on the far left of your screen, and we will answer as many of your questions as we have time for. Okay, let's get started. Jeremy, let's start with you. Can you expand defining prognosis based on zip code instead of genetic code?
Yeah, sure. So in the foundation of the social determinants of health, you can learn a lot about someone's health and someone's ability to manage their health literacy and otherwise based off of kind of where they live. There's a number of studies that are out there, but whether you live in a community that has a high poverty rate, a community that has a severe incidence of pollution, a number of things that can factor in that, all the way back into, there's even studies that I've read back in my MPH days of people who grew up in blue collar homes or single fathers, had different outcomes as it related to their health and well-being, not just physically but also emotionally. And so I share that to say that as you approach any kind of disease burden that you have, being able to understand the dynamics, the social dynamics surrounding a given population can facilitate better insight for how to treat them. And more specifically, in some of these disease burdens, if you can understand the zip codes in your population a little bit better, what you can do is be a lot more proactive in your approach, not only with clinicians, but also with the patients or the people directly. And this can facilitate and open up the door to a completely different way labs can serve their system. We do a number of work with safety net hospitals. And, one of those frustrating things is when you see the person who's coming through the ER routinely from a primary care perspective. And so not only is that costing money, but even what's happening when they're leaving, whether you're giving them some sort of therapy prescription or otherwise, you may find that that's just not going to be effective for keeping them out of the ER 1 week later, maybe 1 day later. And from that perspective, being able to be more proactive, holistic, and strategic, using lab data, using some external data resources, can facilitate from a lab perspective, taking a strategic lead for the institution and guiding the institution in ways to think about how they can get ahead of the disease burden and therefore ahead of the impact it might have to the overall enterprise.
Thank you, Jeremy. Now, Dr. Hayden, let's come over to you. In your HIV example, you were able to analyze those patients that were new infections. How did you implement intervention for those patients to ensure that they got on the right treatment pathway?
Yeah, it's a great question because, like I said, I think there's a very real risk with universal screening that all the lab does is incur a lot of, reagent and labor and et cetera costs and not really impact patients. So the way we were able to do this, the answer really is just Michelle Rose and the STI task force, right? It was having the nurse navigators, having that connection. And so the process is that all of these tests are ordered under our hospital epidemiologist, who's essential leader in this effort as well, Dr. Schultz. And then those results flow to nurse navigators. And so we actually have a human being who is made aware of any of the positives. Now, importantly, in our laboratory, any of our positive screens are not resulted out. They are reflexed through the full confirmatory pathway, right? So when they get a positive, this is a patient who has a confirmed positive. And then those nurse navigators actually reach out to the patients and inform them of the diagnosis, but also of all of the avenues for care and treatment. It's amazing how many times, going to what Jeremy was saying, that we think of barriers to care, but something like being able to afford transportation to doctor's visits can be a substantial barrier to care. And so having nurse navigators who can make folks aware of those resources that are out there and to understand what are the reasons that might keep you from getting on the care pathway. But so honestly, it's the lab was one part in that, and connecting the patients to care through the nurse navigators and having that infrastructure in place was really what made this actually impactful testing.
Thank you, Dr. Hayden. Now another question for you. You mentioned you created an opt-out setting in your EMR for patients. How long did it take to implement the setting?
I was hoping nobody would ask that, right? It's better when it looks so flawless. So, you know, I have used this example before. Epic and EMRs are an awful lot like Amazon. They do some things really well, but you really don't have any options for customization, right? Try telling Amazon that you want them to change how their homepage looks or click options and things like that. You're not going to get very far because they know that they need to build that, they need to maintain that, and Epic and the EMRs are the same way. And so while the Epic team worked a lot with us, you know, they obviously are hampered. And so this is just a very long-winded way of me saying over a year with a number of false starts as the changes that we made caused downstream problems, and then we have to stop and refix and restart. There's potential there, but it's a tremendous amount of work and not something which is a viable solution, in my opinion, given current state, to do more broadly.
Thank you,
which doesn't
Dr.
mean you
Hayden.
can't do it just for one instance like HIV. Sorry, but yes.
Sure, no, absolutely. Now, since we're talking about time, how much time do you spend adding a comment on lab drug interference? This one has a few parts. How many samples a day do you do that for? And do you still get calls from clinicians wanting interpretation of results?
Yeah, that's a good question. So the comments are so as a great example, you know, when we get an IFU, we read through it, we will develop a comment. We append our comments using Data Innovations, DI, and so those are appended effortlessly on the lab side because it's the robots that do that. And we will add those comments as needed or in response to clinician comments. Now, that being said, you know, as a good example, our beta HCG has comments on heterophile antibodies as well as pituitary HCG and middle-aged women, and I still regularly get calls and questions about those. So we spend really zero time during the day adding comments on lab drug interference. We do it for a relatively high number of samples, but I still get a number of calls, which I think highlights that while the time required to add the comment is minimal or zero, the value to patient care is also, in my opinion, not terribly high.
Thank you, Dr. Hayden. Now, let's go with this next question. In certain conditions, it is important to do more than one test for one condition or infection in order to not miss some positive cases to come back negative. How can we push for that?
Yeah, that's a great one. And you know, it's when some things are negative, when some things are positive, right? My old mentor in Seattle, Jeff Barrett, used to always remind me that every laboratory test is a question or a mistake, but typically it's a question, right? The clinician is worried about something, and so they're trying to order a test. You know, in an ideal world, obviously we would just have them ask us the question, you know, does this patient have a sexually transmitted infection, an STI? And then we would order the testing as necessary. Obviously, there's some challenges there, and I think it's essential that we still allow physicians to practice medicine since they have that knowledge of the patient. I think what we try to do is to get reflexive test algorithms approved in advance, and those are things that our physicians really appreciate. So when they order the test, they know up front it's well documented and clear to them. And that's important from some legal billing implications. But you know, they know if this result, then this test. If that result, then this other slew of tests. And that allows them to do the single blood draw and have the laboratory add on. So antibody antigen screen is positive, reflexes. You know, the antibody confirmation is positive, we're done. It's negative, there are some labs who already go on to do the nucleic acid amplification testing, some of those things. So it's about having clearly defined reflex rules, which are approved and made clear to your physicians. And then, in my experience, they greatly appreciate that.
Thank you, Dr. Hayden. Now we have time for just a few more questions. I'd like to open this question up to both of you. What went wrong with the COVID-19 test at the CDC based on your knowledge?
Wow. Jeremy, you're welcome to represent Abbott on that recorded webinar.
Yeah, I don't have anything I could say that I would feel comfortable to say about what went against it from a what was working against the CDC test.
I think that we lose sight of how complex testing is. There is, this growing opinion that it's, you have a lab vending machine in the basement. I'm not saying that's what happened to the CDC, but I'm saying that there's so much complexity of what can happen and what can go wrong. And you add in the fact that, in my experience, laboratorians chose to be laboratorians because we like to have the time to sit, to ruminate, to think, to search PubMed, to speak with colleagues. And then you put us in this situation where we need to almost act like ER doctors and quickly triage and make decisions under stress in stressful times. It's challenging.
Thank you both. And let's wrap with this final question. This is open for both of you as well. Now, this is such a realistic and helpful approach to the best outcomes. However, this is preaching to the choir. Are hospital or system administrators getting this education?
Yeah, so I'd happy to jump in on this, Dr. Hayden, and feel free to pile on. Here's my perspective. I've been preaching, I guess, this message for, I would say, going on almost 12 years, right? Looking at the healthcare ecosystem, understanding the central theme of the lab and all the impact that it can make, and it's a really good question. What I would say is, is we use the metaphor of preaching to the choir. It's not enough. The message we're here is being delivered across the board, but it's kind of the choir's responsibility to get people to church, right? There's a message in here that maybe is latent. It's not the message is the lab is valuable. That's not the message. That's not the central theme of the gospel. The central theme of the gospel is the lab needs to do some different things to facilitate, making this change, because we've been saying this for a very long period of time, all of us collectively understanding the value that it creates and talking about it. But at the end of the day, talking about it's not sufficient. And continuing to do what we've always done and stay under the operating model. And I know this is easier said than done, so please don't take this as, of course, this is easy. Staying under the operating model and the metrics that we've been playing from, is what's hurting us. So what the call to actions here are a couple. One is take some time to actually build a written strategy for the lab in a way that's presentable to the C-suite. So that what you've got is you've got a way to demonstrate, not defend the value you're creating today, but to illuminate the value, incremental value you could create. What the C-suite and executives and payers, they don't want to hear about how good they have it. They want to hear somebody step in with solutions that help them move forward, that create incremental value. And so, kind of message one is, build a strategy, a roadmap, an identification of where this new value can be created, of how the lab could be used differently. And so that's kind of one central theme. The second central theme is rethink the operating model that you have in terms of, not only building a strategy, but how do you execute day in and day out? What are the things that you do? What are the activities that you have that enable you to step outside the four walls of the lab into the patient pathway, into working directly with clinicians hand in hand. What are those behaviors that are different and new that increase your visibility? And the third domain is centered around the tooling and control, as was mentioned earlier, is how do you locate those things in your hands, right? I often joke with people, it's like, I'm horrible at DIY. And, in some cases, the EMR is like my dad, who's a master craftsman, trying to explain over Skype how I'm supposed to put together a cabinet. Now, of course, he can tell me, right? He can give me some insight, and I can ask him some questions, and and he can point me to the instruction manual, but I don't necessarily have the tactile skill for it. And so what I would encourage you to think about is the third call to action is try to ensure that you've got the tooling inside the four walls of the lab and the lab's control to facilitate, whether that's clinical decision support, whether it's business intelligence, however you want to take a look at it, so that you're able to use your data, you're able to access it, you're able to control for how you look at it, and you're able to be in a position to take an active role with the executive on the strategy or with the clinicians downstream. So it's not as much as it is kind of preaching to the choir and needing the choir to get people to the church. The gospel is slightly different. The gospel is not we're valuable. We know that. The gospel is, hey, let's change. Let's build strategy, written strategy aligned to the executive so that they can see the value we could create that's incremental. Let's outline and start to execute different behaviors that make us visible, that help us integrate into the patient pathway side by side with our clinicians and with our patients. And that third domain is let's tool up the lab differently. Let's make sure that we have control and we have the tools required to actually create this value. And I know that's easier said than done, and I don't mean to be, to make it, just oversimplify it. Those are real challenges that I know many of you have tried. But at the end of the day, telling people the lab is valuable is not going to stimulate any development or investment in the lab. Us acting our way into a new realm of being is the only pathway that's going to end up with people really genuinely recognizing what we do. I don't know, Dr. Hayden, if you'd have anything more to add to that or any additional perspective.
I think it's well said from you. I think the one thing I would add is that I always have to remind myself, and I think we as laboratorians need to remind ourselves, that it's not enough to be speaking this message to the C-suite. We need to speak in a language that they understand and what matters to them. It's very easy to sort of dismiss some of the concerns they might bring up or objections or to think that you're just miscommunicating, but really effectively communicating to them is understanding sort of, as Jeremy was saying, what are their strategic priorities? What do they value? When they look at something, how are they thinking about it? And making sure that you're doing your best to talk their language and align what you are doing in the laboratory with what they want done. And so, I think it's a challenging conversation. I think it's happening. I think that there are things both sides can do to make it probably more impactful, but certainly from the lab end, making sure that you are speaking their language and communicating in a way that they understand and you're aligned with your institutional priorities is something that we can do to better communicate that.
Thank you, Dr. Hayden. And thank you, Jeremy, both for your insight on our Q&A today. Do either of you have any final comments for our audience?
Just thanks for taking the time, especially at a time like this.
Yeah, I would just echo that, and thank you, everybody, for what you're doing out there to make our community safe and get through this. And, as we kind of hit on a little bit at the beginning is, let's all keep helping each other out, and we're gonna get to the other end of this stronger as a discipline and stronger as a country. So thank you so much.
Thank you both for today. And before we go, I'd also like to thank our audience for joining us today and for their interesting questions. We had quite a few questions we were unable to answer today, And those questions that we were not able to answer, and any that come in during the on-demand period, they will be addressed by our speakers via the email address you provided at the time of registration. One final thank you to Jeremy Schubert and Dr. Joshua Hayden again for their time today. We'd also like to thank LabRoots and our sponsor, Abbott Diagnostics, for underwriting today's educational webcast. This webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. You will now be redirected to the registration page for Chapter 3, Clinical Care Integration, broadcasting live next Monday, March 30th at 8 a.m. Pacific Time, 11 a.m. Eastern Time. We hope to see you there. Have a great day.